The ECCP committee is also focused on taking a leadership role in collaborative community efforts to address this issue. To learn about the ECCP committee, please visit www.orohc.org. At this time, I'd like to introduce our presenter today. Karen Hall is an expanded practice dental hygienist that provides the First Tooth training and also works with staff on site to ensure they are comfortable with providing the services and using the tools. First Tooth has some great materials and tools that sites receive free with training. She also offers technical assistance after the training to help with screening and fluoride varnish applications during scheduled appointments, as well as determining the most efficient workflow for your office. And at this time, I'd like to welcome Karen Hall.
Thank you for joining me in the Oregon Oral Health Coalition in our First Tooth webinar. This First Tooth webinar is designed to be an introduction to First Tooth so that your office or organization can schedule the training to become First Tooth trained. First Tooth is a no-cost training, and we supply all the training materials, and we even provide the trainees with breakfast or lunch. The implementation portion of this First Tooth training today will be broad. During an in-office training, we offer specific technical assistance to help implement ECCP services in your office or organization. Also, physical materials will not be provided for this training. Please visit our website to access multiple free materials that can be printed directly from your computer, and also view what materials are available for order. We also want to welcome our fellow out-of-state and out-of-country DentaQuest grantees joining us today. This webinar will act as an introduction to Oregon's ECCP program and give you an example of how a similar program could be designed in your state or Canada. When developing the First Tooth curriculum, many other successful programs across the nation were researched. Programs such as Maryland Mouths Matter, Into the Mouths of Babes, Washington Dental Services, ABCD, and Smiles for Life were all generous in sharing ideas and resources. The National Maternal and Child Oral Health Resource Center continues to provide relevant resources and updated references for First Tooth. In 2009, the Oregon Oral Health Unit, in collaboration with OROX, launched the First Tooth program. The program transitioned to OROX operational control in 2012. Since 2010, First Tooth has trained over 2,000 medical and dental staff throughout Oregon. First Tooth is currently funded by DentaQuest and the Ford Family Foundation. We will have a Q&A session after the First Tooth training today. Please use the question box to submit your questions or comments. CE/CME credits are available to those who stay logged into the webinar, and all Oregon trainees will receive a CE/CME certificate via email by the end of next week. All right, let's get started. The main goal of First Tooth is to expand the oral health workforce in Oregon so that preventative health services are delivered to the very young child, ultimately decreasing early childhood caries. Physicians, nurses, and other health professionals are far more likely to see new mothers and infants than dentists through the well-child checkup system and schedule. These non-dental health professionals can be engaged as partners to advocate and support early childhood oral health. We also provide training to general dentists who have not traditionally seen young children in their practice, helping them to develop workflows and implementation strategies to integrate that very young dental patient. In the last few years, First Tooth has trained in most counties of Oregon, but there are still many untapped regions where children are not getting their early childhood caries prevention services. When local oral health champions leverage their resources and contacts, they're far more likely to know these unreached populations. We will rely heavily on local support to continue ECCP services being delivered long after our funding for this grant cycle concludes. Our goal is to be able to provide materials long-term, but have local partners help to provide the trainers. Lastly, First Tooth works diligently to facilitate collaborative referral relationships between medical and dental providers, as well as Head Start, Early Head Start, WIC, and any entity who sees children in that 0 to 3-year-old population, so that ultimately all children will have access to a dental home. Let's get started with discussing the prevalence and the impact of oral disease. There are many acute and chronic effects early childhood caries can have on children. The child may experience acute pain, but more often than not, they have no pain at all, or they don't necessarily register what their experience is as pain. Many of you see children with early childhood caries and may say, gosh, that child might have so much pain, or that must hurt a lot, when they don't actually have pain, or they say it doesn't hurt. Or the very young child, like the 2-year-old or 1.5-year-old, they're not necessarily crying or complaining, but that might be manifested in different ways, like maybe they're a picky eater, or they don't like to eat hard, crunchy foods. So those are all signs that there's something going on in the mouth. There's also a risk that the infection can spread and cause a cellulitis. Research shows children suffering from early childhood caries have an inability to concentrate. They have a general malaise or low-grade fever. They can have impaired language development, particularly if those upper front teeth are taken out too soon, and they suffer from low self-esteem. Other long-term effects include malocclusion in the permanent dentition if baby teeth have to be removed before their natural exfoliation, extensive and costly dental treatment initially and over the lifetime of the child, and increased likelihood of chronic caries even in the permanent teeth. As many of you know, the State Oral Health Unit conducts a SMILE survey every 5 years. After an alarming upward trend in oral disease in our young elementary-aged children from 2002 to 2007, the latest report shows those trends improving. We know that many successful fluoride and sealant programs throughout the state have likely played a part in this improvement throughout Oregon. Clearly, we see that we need to continue building on the great work being done in our state to continue to see improvement in the coming years. First Tooth is just one of the programs designed to play a part in this improvement. Not surprisingly, the SMILE survey shows disparities in the oral health of Oregon's children. Children from minority families and lower socioeconomic homes have substantially higher rates of decay, untreated decay, and rampant decay. So why is one of our targets the pediatric providers? Pediatric providers ideally see young children as many as 7 times in the first year of life and up to 11 times by the time they reach age 3 for well-child visits alone. So these interactions can provide a great opportunity for anticipatory guidance, screening, oral health maintenance, and preventing oral disease. A vast minority of children visit a dentist prior to their 3rd birthday, despite the American Academy of Pediatric Dentistry, American Dental Association, American Academy of Pediatrics, and other national organizations who have policies encouraging initial dental visits by age 1. Several factors can contribute to this, including limited number of dentists who treat children under 3, few options for Medicaid patients, parents not understanding the importance of preventative services, and access to care challenges. There's an opportunity for pediatric medical providers to incorporate oral health into well-child visits so that children with limited access to dental care can maintain good oral health until they are able to access appropriate dental professionals. The American Academy of Pediatrics has been an influential leader in oral health integration into the medical setting. They have published many articles about oral health and launched an oral health initiative, which includes a website containing a wealth of information and resources. Their policy statement, released 10 years ago, states that all children should receive an oral health risk assessment by 6 months of age. Babies who've been determined to be at risk of developing caries or who fall under recognized risk groups should be referred to a dentist no later than 12 months of age. Many of you may be familiar with the concept of a dental home, which was derived from the concept of the medical home. National organizations such as the American Academy of Pediatric Dentistry, American Dental Association, American Dental Hygienists Association, and the American Academy of Pediatrics support this concept, which is that the oral health care should be continually accessible. So that means that it's not just somebody that comes in and provides a service once and doesn't continue to be able to provide services for the family. That it's comprehensive, it's not just emergent care only, that it's family-centered, and that the whole family plays a part in the oral health of the child. That it has a coordinating aspect to it, so they coordinate with medical and other dental professionals, and of course is compassionate and culturally effective. It should be delivered by a well-trained dental professional who implements preventative dental health habits that meet each child's unique needs. However, since there's many different places dental care is delivered, the dental home might not look like the traditional four walls of a dental office, particularly in Oregon with the mid-level providers. There are now opportunities for dental professionals to be partners in dental home, but not actually work in a clinic. Examples include working in school-based health centers, Head Start and Early Head Start, WIC offices, Boys and Girls Clubs, and medical clinics. The dental professional is making access to the dental team easier by expanding the team by going to the patients rather than hope the patients come to the dental clinic. So what are the specific early childhood caries prevention services we recommend? You will see that we're asking medical providers to assess, screen, educate, intervene, and refer. Again, we're looking to medical providers because they're in the best position to provide these services. They see children frequently in the first 3 years of the child's life. But as you can imagine, the services they provide is limited, as they have an average of only about 20 minutes for the entire well-child visit. So we rely heavily on the dental providers to provide similar but more comprehensive ECCP services. We're going to go through each of these preventative services in more detail, and you'll be able to see how you can implement these into your well-child visit. Keep in mind, medical providers, that you're already doing many of these things during your regular well-child visit. I'll be able to give you examples of how to continue what you're already doing, but modify how you say things or what you're already looking at to see the earlier signs of decay to get that child on the path of oral health early. All right. Module 2 takes us through the assessment, the risk assessment for caries, but we're going to back up just a little bit and look at the decay process so we're all on the same page there. So caries is a process of actual decay from early demineralization of the tooth structure to the actual cavities or holes in the tooth. So we're encompassing that entire process of decay. Early childhood caries occurs in the primary teeth of infants and young children. This condition can progress pretty rapidly, in part because the enamel of the primary teeth is thinner than that of permanent teeth, and also good oral hygiene habits haven't necessarily been established in the very young child. Early childhood caries affects teeth that are least protected by saliva, and often early childhood caries is associated with the use of frequent feeding at nap time and bedtime. Thus, the more common term bottle rot or bottle mouth syndrome is more commonly known to families and also to providers. The first sign of caries is demineralization of the tooth structure, producing a white spot. White spots place the child at high risk for developing cavities and require immediate intervention because those white spot lesions actually can be remineralized. White spot lesions first appear at the gum line of the upper front teeth. Those areas often missed when brushing and where there's limited saliva contact. Immediate interventions include using fluoride varnish, the use of fluoridated toothpaste, and behavior modification for improved brushing and dietary habits. Where dental care is available, it's important to make a timely referral to the dentist. The dentist will be able to apply additional topical fluoride and provide more comprehensive treatment. I often get asked about fluorosis and how to know the difference between fluorosis and white spot lesions. First, fluorosis affects the permanent teeth, since it's a complication of excessive amounts of fluoride ingested while those teeth are forming. It also gives an overall lacy look, whereas demineralization white spots occur mainly at the base of the tooth along the gum line. So these pictures show the pattern of early childhood caries. Notice how cavity-free those lower front teeth are, those teeth that are bathed in saliva. Also note the abscess in the lower left picture. It's important to lift the lip to assess the tissue at the area where the end of their tooth's root is to determine if the tooth is abscessed. Abscesses are just like abscesses in other parts of the body. They usually manifest like a bubble or a deflated bubble. The American Academy of Pediatrics flip chart and office guide to pediatric oral health are two of the educational resources available on our website. Both these guides can be used to show disease progression to your families. Early childhood caries is a complex disease, but simplified, it takes 4 main factors to cause caries. Bacteria in the dental plaque adheres to the tooth surface. There are many types of bacteria in the mouth, and not all the bacteria cause cavities. The bacteria most associated with caries is Streptococcus mutans. When Streptococcus mutans ingests carbohydrates, they produce acid, which over time causes caries. Caries, like other diseases that our bodies are constantly fighting, is a disease in constant battle between the protective factors and the pathological factors. Protective factors include the strength of the enamel and the amount of salivary flow. So we look at if there's been enough adequate fluoride available to build and maintain that hard tooth structure, and also if there's been enough fluoride available when those teeth are in the mouth to make that outer layer of the enamel be extra strong. We also consider the amount of salivary flow. So there should be enough saliva present to buffer the acids and to bring the mouth back to healthy pH levels, as well as rinse away additional food particles. Pathological factors include those caries-causing bacteria, the amount and frequency of fuel source or carbohydrates for those bacteria, and a reduction in the salivary flow. When there's too many pathological factors present, the teeth are at higher risk for getting cavities or caries. They must be counteracted by decreasing the pathological factors and increasing the protective factors. This graph shows the difference between eating carbohydrates only at meal times versus meal times and frequent snacking. Bacteria produce acids in the mouth for about 20 to 40 minutes after the ingestion of carbohydrates. The steady source of sugar carbohydrates results in almost a continual exposure of the teeth to the acids. Remineralization occurs when the acid is buffered primarily by the saliva. Frequent ingestion of carbohydrates then results in virtually no rest period for that enamel to remineralize. Practically speaking, however, the young child eats snacks or drinks beverages with carbohydrates between meals. If we think about a typical 2-year-old, they're having usually frequent snacks between their meal times, and those snacks are often carbohydrate or juice related. It's important to encourage carbohydrate-rich foods to be limited to meal times and encourage drinking water after snacks to help return the mouth to a healthy pH. There are certain foods that are more tooth-friendly than others. This take-home sheet for parents is a guide to choosing healthy snacks for oral health. This handout, like all of our other handouts for parents, comes in English and Spanish and is available to print off our website. Notice that the healthy snack list is similar to the list of healthy snacks a medical provider is already recommending. A way to integrate an oral health message is when giving snack recommendations to say these snacks can also help prevent cavities. Likewise, when dental providers are providing tooth-friendly snack choices, they can cross-message by saying that these tooth-friendly snacks can also help maintain a healthy weight or maintain adequate vitamin intake. So how do these children get these cavity-causing bacteria? Transmission of oral bacteria is through saliva, through normal day-to-day activities. The transmission of oral bacteria appears to be primarily from mother to child, or from the person who spends the most waking hours with the child. Surprisingly, the child's oral bacteria is established by the time he is 2 years old. Recognizing that these bacteria are passed from mother to child makes it important to instill that message to the mother that her own oral health is important. If she can minimize the bacterial load in her own mouth by improved oral health, then she's less likely to pass on those pathological bacteria to her child. When the mother passes less overall bacteria to her child, the colonization of those caries-causing bacteria is delayed, lessening the chance for early childhood caries in the child. So in addition to recommending early and regular dental care to pregnant women and mothers of young children, good oral hygiene, the use of xylitol gum, and chlorhexidine rinses can also decrease bacterial loads in the mouth. So it's important to keep the key messages then that the bacteria will be transferred from the primary caregiver to the child, but we want to lower that bacterial load so that less bacteria is passed on to the child. So when we think about pregnancy and oral health or dental care in pregnancy, there's a lot of conflicting messages regarding the safety of dental care during pregnancy. We're not going to go into a lot of details about that today, but we just wanted to point out that fortunately the National Maternal and Child Oral Health Policy Center gathered a work group to study and create this consensus on the safety and importance of oral health and dental treatment during pregnancy. This consensus statement was developed to help medical and dental professionals provide pregnant women with timely oral health care. You can access this document from the Maternal and Child Oral Health website listed here on this slide. The first early childhood caries prevention service we will discuss is determining the patient's risk for caries. So what is the purpose of risk assessment? When the risk of caries is assessed, it's much better utilization of time and resources to address the problems to the child who needs it the most, just as you would spend more time talking to a child at risk for diabetes about diabetes. A child with a high risk of early childhood caries will need to be referred to a dental home sooner than a child at low risk. It was earlier mentioned that referrals to a dental home should take place as early as 6 months old or when that first tooth erupts for children at high risk for caries. Aggressive intervention of fluoride varnish and daily fluoride use is also dependent on the risk. Fluoride varnish is not indicated for children at low risk of caries if they're under the age of 3. The use of fluoridated toothpaste is recommended as soon as that first tooth erupts for children at high risk of caries. And the amount of time spent on anticipatory guidance and education will also be determined by the level of risk. So we're putting the time and resources into children at high risk for caries to get the greatest benefit. So there's a lot of great risk assessments out there. Dental providers often use very comprehensive risk assessments like the American Dental Associations or the Canberra system for risk assessments, and those are really great. We happen to choose this particular risk assessment for medical providers. First of all, they don't need that comprehensive of a risk assessment to determine a child's risk, and the easier it is for them to go through it, the more likely that it is going to be implemented. The other reason why is because this risk assessment is the one that the American Academy of Pediatrics recommends, and it's also in that flip book that I referred to earlier. So when we look through these risk categories, you can see that as a rule, the medical providers already gathered a lot of the information they need to assess the caries risk, even before they've seen the child. So this risk assessment, if a child has one of these risk categories, they're at least at a moderate risk of decay, and 2 or more, they're at high risk of decay. So medical histories and intake forms then have already got built-in triggers to help gather some of this information. As you can see, many of these things you've already known, and by looking at their medical history or just by knowing the family history. So we're going to go through each of these individually. So children that are low socioeconomic, I mentioned earlier that they're at higher risk of getting decay, and there's a lot of factors that play into that. When you think of your family and your populations that are low socioeconomic, there's a lot of things that would put them at higher risk of getting decay. Not only are they more likely to be less dentally insured, but they have transportation issues. Oregon has a very complex Medicaid system, and it's daunting and difficult to navigate, particularly with some of the CCO transformation that we're going through right now. Those changes are happening at a very rapid rate. So a lot of families are confused about how to get the services. Parents that don't have a regular source of dental care often have difficulty getting their kids into regular dental care also. I mentioned transportation issues, and also dietary things can play into that for families that are low socioeconomic. We already mentioned why children with plaque and white spot lesions are at higher risk of decay, and we talked about the transmissible nature of the disease. Children that were premature or had low birth weight, oftentimes the enamel on those baby teeth have micro defects, and so those teeth are at higher risk of getting decay. Children with special health care needs, this could be either developmental disabilities or children that are chronically ill. If we think about children that have developmental disabilities, there's a lot of things that are going to put them at higher risk of decay. Primarily, it's maybe difficult to clean their teeth. Their diet might be much different than a child without developmental disabilities. And frankly, oral health care may not be high on the priority list of things to accomplish by the end of the day for parents with children with those kind of disabilities. Children that are chronically ill are often taking medications that are laden with sugar in oral suspensions that are sweet and sticky so that the child will take them. And so it's important to remember to instruct the parents to either rinse the mouth after taking some of those medications or brush the teeth afterwards. Additionally, medications like asthma medications can dry the mouth out, therefore making a lack of saliva present to neutralize the mouth. So while ethnicity alone isn't a risk factor for dental caries, there are certain populations that are definitely at higher risk for getting dental caries than others. The 2000 Surgeon General report stated that American Indian, African American, and Hispanic children are all disproportionately affected by caries, even controlling for socioeconomic factors. Among these populations, there's an increased rate of dental caries and decreased rate of dental visits. Beliefs about health, disease, diet, and hygiene in different cultures may create additional oral health risk factors through dietary and feeding practices and child rearing habits. Our next module takes us through education and anticipatory guidance to give to the parents. It's one thing for understanding concepts as healthcare providers, but sometimes it's difficult to teach using words or concepts that parents understand or that motivate towards change. Providing anticipatory guidance that's consistent with messages the parent hears from other sources in a way they can put it into practice is the key to behavior changes. Misconceptions about the importance of baby teeth also can contribute to the reason children are not accessing dental care. It's new information to some people that primary teeth are important for normal development of their child. It's not uncommon to hear parents say baby teeth will just fall out, so why fix them anyway? Additionally, it's important to keep treatment costs for the family and for the dental care system low by utilizing the dollars spent on prevention versus treatment. For example, low-income children who have had their first preventative dental visit by age 1 are not only less likely to have subsequent restorative or emergency room visits, but their average dentally related costs are almost 40% lower over a 5-year period than children who receive their first preventative visit after age 1. Many of you have had great training in motivational interviewing and messaging. Personally, my experience with motivational interviewing was infrequent and practicing techniques felt awkward and rote. Done well, though, motivational interviewing can be the key to parent buy-in and follow-through. Motivational interviewing is a technique to engage that parent in active participation of improving the health of their child by establishing a rapport with the parent and providing a menu of options for improved oral health and caries prevention behavior. They can help the parent to identify discrepancies between their current behavior and good oral health for their child. Motivational interviewing differs from the traditional medical and dental counseling by creating a collaborative effort where the parent and the practitioner are equal partners and work together to improve the health of the child. My training as a dental hygienist was not very great in motivational interviewing, for example. Like many of your dental hygienists, I wait to impart all of my glorious wisdom upon my patients when their mouths are wide open. So those are not very good motivational interviewing techniques. So this is something that particularly dental providers need a lot more work in. Engaging the parent well, gathering the information is important, and you can do that through asking open-ended questions and affirming the patient in something that they're doing right, reinforcing that they can make those changes so their self-efficacy can be their cheerleader, and also using reflective listening and summarizing skills. Those of you who have had motivational interviewing training, sometimes that feels really awkward to practice that, but the more you do it, the more natural it becomes. So if you want more information on motivational interviewing, we adapted a document called Explore, Offer, Explore, and it's a guide from WIC that we adapted to be more oral health specific. So this motivational interviewing tool was adapted from the Indian Health Service to help with that messaging and education. You can use this tool chairside to give the parent a visual of the changes that they could make in regards to improving the oral health of their child. For example, you could say, here's some things that would help your child's teeth to be healthy and prevent cavities. Is there something on this chart you'd like to work on in the next 3 or 6 months, whenever I'll see you next, to improve the health of your child? And they may choose, for instance, oh yeah, well maybe we can try drinking plain water instead of soda pop. And then you can circle that for them and say, that's an excellent thing for you to want to work on. And then the next time they come in, you can say, last time you were in, you chose that you wanted to work on putting plain water in your baby's bottle or sippy cup. How did that go for you? And then take it from there. So in essence, you're empowering the parent to make the changes, and you're holding them accountable for the changes that they want to adopt. Notice that the tool has a lot more pictures and less words. So it's often helpful when you're teaching new information to limit the message to simple words such as choose fruits and vegetables or drink plain water between meals, rather than go into details about the reasoning behind all those suggestions. If they have questions about them, you can certainly talk more fully detailed to them, but using fewer words and more pictures is just great motivational interviewing techniques. We designed our educational posters with the clinical office in mind with regards to the size and the content. There are posters which address pregnancy, babies, and toddlers, as well as specific toothbrushing and toothpaste tips. The posters are available in English and Spanish, of course, on our website. Some offices have found that they like to print them off into an 8.5 by 11 size and use them as handouts. The pregnancy poster gives parents information about the importance of minimizing that transmission of disease and lowering their bacteria load. The babies and preschool posters summarize preventing caries through behavior modification. We also share our posters with WIC, Head Start, and Early Head Start to improve that consistent messaging for the parents. Our goal is to encourage medical providers, dental providers, WIC counselors, and Head Start counselors to teach those consistent messages so the parents can understand that they can prevent dental disease in their children. Consistent messaging decreases confusion and reinforces oral health messages in the various places that patients and parents are receiving oral health messages. Using different types of education can also reinforce key messages. There are many different ways to teach oral health to your patients. The DVD Early Childhood Caries or Get Healthy Now Sesame Street DVD can be played in the waiting room or exam rooms. We also have brochures, the AAP flip chart, and the pocket guide that are great educational tools. The language barriers make gathering information and educating a challenge. So whenever possible, of course, you want to use interpreters or materials printed in the patient's primary language to decrease those misunderstandings. While language barriers exist, though, more often some of the problems that we deal with are in differences in health literacy. And health literacy is that degree to which the patient or the individuals can listen to, process the information, understand the information, and then use that information to make appropriate healthcare decisions. So using an appropriate literacy level in terms of words, medical terms, limiting unnecessary statistics or difficult concepts, those are all important and show respect to the caregiver's level of health literacy. Again, using handouts that are have more pictures than words can help bridge gaps in health literacy. You want to make sure that you also strive to keep the information accurate while you simplify the message, and that can be a big challenge when providing more simplified education for oral health. So specific information for prevention of early childhood caries through diet and feeding is similar to information particularly that medical providers are already giving their parents for healthy dietary habits. Breastfeeding doesn't increase the risk of caries alone. It's most important to keep in mind that you want to hold the infant for bottle and breastfeeding so that the child's not having a constant pooling of milk on the teeth. Also, you want to introduce water in the bottles prior to bedtime or naps to prevent milk pooling on the teeth if the child falls asleep with the bottle or at the breast. Infants should be weaned from the bottle between 12 and 18 months. And the use of sippy cups and pacifiers early on is, of course, not necessarily a problem as long as there's only plain water in the sippy cup and that the pacifier hasn't been dipped in honey or sugar or something else like that. We discussed on how snacking on carbohydrate-rich foods or grazing doesn't allow for the saliva to buffer the acids in the mouth and return the mouth to a healthy pH. Regardless, some parents are going to continue to give several carbohydrate-rich snacks throughout the day. So you want to just encourage them to have plain water in sippy cups or to drink plain water after those kinds of snacks to get the mouth back into a healthy balance. Again, as medical providers, you're already encouraging parents to make healthy choices when preparing meals and snacks for your children. Since so much of this oral health diet and feeding tips is information you're already giving to your patients or parents, adding a tagline such as, "Keep in mind that these healthy snack choices can also prevent your child from getting cavities," is a great way to integrate an oral health message. Likewise, dental providers can cross-message to encourage getting proper nutrition for health when they're giving snacks, teeth-healthy snack information for parents. Of course, practicing good oral hygiene is another way to prevent cavities or caries, and giving tips for improving daily oral hygiene can really improve those caries outcomes. I want to make sure that you show the parent how to use the lap method of viewing the children's teeth, much like you use a knee-to-knee screening, which we'll talk about in a little bit. One way is to have the child sit in the parent's crossed ankles and rest his head in the lap of the parent. In the picture, you can see how I'm sitting on the edge of the tub. It's much easier to utilize the overhead light than to see the mouth. Then when the child is sitting on the edge of the sink and you've got the light in the mirror behind you and you're looking into a dark cave. Before the teeth start to erupt, you want to make sure you're using a soft cloth or a really soft toothbrush to get the baby's gums clean after drinking milk. And then as the child gets teeth, you want to use an appropriate sized toothbrush with just a smear of fluoridated toothpaste if the child is at higher risk of decay. Remember to have the child spit out the toothpaste and not rinse the mouth with water afterwards. This method allows the teeth to bathe in fluoride after brushing. Young children do not always spit out their toothpaste, so it's important to just use a very small amount of toothpaste. We recognize that there's a lot of confusing information about how and when to start using fluoridated toothpaste. So we created a chart called Recommendations for Fluoride Usage for your use. Again, it's recommended that children at high risk of caries use fluoridated toothpaste when their tooth first erupts. Another key is to be consistent with brushing before bed and after breakfast. Some families just brush at night once a day, and it's important that nighttime is the best time to brush if they're just going to brush once a day. I'm going to make sure all the surfaces of the teeth get brushed and lifting up that lip to ensure plaque removal at the gum line. Young children have difficulty brushing all the surfaces, so daily supervision is important. One thing I notice when I have even 7- and 8-year-old boys demonstrate their brushing skills to me, they usually can't do it very well. So that fine motor dexterity sometimes doesn't kick in until they're quite a bit older than we would expect. It's also helpful to use the tell, show, do method when you're teaching brushing skills so that the parent can show you how they're checking the teeth and you can show them areas that the child needs improvement. We talked about fluoride's role in strengthening teeth. Systemic fluoride is fluoride designed to be ingested, of course. And many years of research has shown that without a doubt, the most cost-effective way to reduce caries is optimum levels of fluoride in the water supply. The CDC and Prevention reports that for every $1 invested in fluoridation, $38 of dental treatment costs is saved. In addition, Medicaid dental programs cost as much as 50% less in fluoridated communities compared to non-fluoridated communities. Despite the research on the safety of water fluoridation, Oregon ranks low in the number of water systems with adequate fluoride at only 22.6%. Supplementation in the forms of drops and tablets is still advocated when fluoridated tap water is not available. The child's caries risk level will determine how much added fluoride should be recommended. There are many topical fluoride modalities used to strengthen that outer layer of enamel once the teeth have erupted. In addition to the types patients can use at home, high-concentrated professional applications can be applied in a clinical setting. Medical professionals may apply fluoride varnish for children at high risk of caries. Knowing how much fluoride is in the water is important, and this CDC website helps keep an accurate data on community water fluoridation levels. It's also important to keep in mind that many people do not drink tap water, so even if they live in an area that has optimum level of fluoride, the families may not be drinking the tap water, so that's an excellent follow-up question when you're discussing drinking water. Fluoridated bottled water is also available in the stores if they don't have adequate water or fluoridated water available. The American Dental Association, Academy of Pediatric Dentistry, AAP, and the CDC all are recommending fluoride supplementation for children who don't drink tap water that's optimally fluoridated. And this is a chart that you no doubt are already using to determine the supplementation recommended for children. Applying fluoride varnish is very effective in caries reduction. Research shows that application of fluoride varnish can reduce tooth decay between 30 and 69% in the primary teeth of children at high risk of decay. Fluoride varnish is also very safe. There's no preservatives, BPA, or added dyes. And the thing I like most is that it's not absorbed through the stomach wall, so the risk of toxicity is minimal to none, and you don't get that, oh, I just had fluoride taste if you swallow it. There are no evidence-based contraindications for fluoride varnish, and applying the fluoride varnish may only take an additional 30 seconds to apply when you're doing your oral exam. It's important that parents and caregivers understand that their involvement is key to managing the child's risk of oral disease. So success in treating early childhood caries happens when the caregivers understand that they're the ones responsible to take an active role in preventing disease by improving the daily oral hygiene and dietary behaviors. We just can't expect a 2-year-old to do an adequate job of brushing and making good dietary choices. In addition, intervention with fluoride varnish at the early stages of decay can reverse the decay process and decreases that chance of more invasive treatment later. Lastly, accessing a dental home can decrease the prevalence of severe early childhood caries by that careful management of oral health habits and disease progression. Once the child is established in a dental home, the dental home then will be responsible for providing the fluoride varnish, and the medical provider can just reiterate the importance of dental visits. All right, the last module covers the implementation of an early childhood caries prevention service program. I mentioned at the start of this presentation that this model is covered much more in depth when we provide technical assistance to the offices ready to make those changes in their workflow and to start providing ECCP services. As a primary care provider, the visual screening of a child may take not any more than an extra minute of your time since you're already looking in the mouth. Dental providers can also use this knee-to-knee technique to have better visual access for the child and to use the parent to help hold the child. The key is to place the child on the parent's lap, facing and straddling the parent. Sitting knee to knee with the parent, the child is laid back onto the parent's and the provider's lap. This allows you and the parent to use the overhead lights to see inside the child's mouth. The parent holds the child's hands and legs so that the provider can cradle the head and the hands and use the fingers to look inside the mouth. Some medical providers already have the child up on the tabletop, and if you're more comfortable using an exam table, you just want to make sure that the parent is positioned in a similar fashion and helping hold the child by straddling the parent. So you want to use like the corner of the exam table. This is really hard to describe without having a table there in front of me to show you. When looking in the mouth, it's important to lift the lip, allowing you to see all of the teeth and the gums. You can use this time to show and explain to the parent what you're doing and what you're assessing. Make sure the teeth are coming in when and where they're supposed to. It's not necessarily important to memorize eruption sequences, but a general understanding of approximate eruption is helpful. For instance, a 2.5-year-old should have most or all of their primary teeth. It's not uncommon, however, for a 2-year-old to only have 6 or 8 teeth, though. So to alleviate the mom's concerns, because as you know, it's most likely the mother who's most concerned if their child's teeth aren't erupting like other 2-year-olds, you can assure her that this is normal and give some anticipatory guidance that once her child's friends in kindergarten start losing their teeth, that your child probably will start losing their teeth a little bit later. So it just kind of gives some comfort to the parent if they're concerned about that. You want to assess the oral hygiene or the presence of plaque or debris on the teeth. The plaque is often tooth-colored, but it gives that textural look to the tooth surface as opposed to a shiny, smooth, clean tooth. You may need to remove heavy plaque with gauze to look for those white spot lesions. Again, you want to lift that lip all the way up to assess the area of the gums where the ends of the roots are to see if there's abscesses there. You can provide education at that time about removal of plaque and debris using that appropriate size toothbrush. All right, next we have an example of how this process can work in the medical office. So we'll show a video right now. Hang on just a minute. It looks, oh, here we go.
This video will provide instructions on performing oral health assessments and applying fluoride varnish on young children. The first video shows a physician applying varnish in a real-life setting, followed by a more detailed overview. The provider examines the teeth using the knee-to-knee position. The caregiver lowers the head into the lap of the physician and holds the child's arms down at the child's side. The physician is examining the teeth for signs of decay, drying them with gauze, and then painting the varnish on all the tooth surfaces. The whole process only takes 20 or 30 seconds. The physician also uses this time to provide education on caring for the child's teeth and visiting a dentist. To begin,
okay, those of you who have done fluoride varnish applications know that that happens very frequently. It's not uncommon for the child to cry, and as most medical people tell me, that way we can look inside the mouth. Dental people sometimes get a little bit more nervous about that sort of thing. Okay, let's summarize the fluoride varnish application. We have a fluoride varnish application document that can take you through the steps of the fluoride varnish application. Some offices find it handy to post that where the fluoride varnish toolkit is stored. You want to make sure you have everything ready. It may be easiest to have individual setups made in advance, like either wrapped in a paper towel or a bib, to be in the exam room so that when the charts are ready, scrubbed at the beginning of the day, you just grab your little packet and you're ready to go. Some providers find it helpful to stir the fluoride varnish and put it on the glove first, like it showed in that video. That way you don't have the child back and then you're trying to open up the varnish and put it on while the child is making a ruckus. You want to position the child either knee to knee or tabletop, and then usually the child's going to open right up and then it'll be easy to get inside the mouth. But sometimes they close their lips down super tight and don't want to cooperate that way. So you can sometimes use your toothbrush to prompt the opening. You can slide the toothbrush between the teeth and the cheek and then leverage that mouth open by taking the toothbrush distally, I guess. This is hard to do and not to show you. If you keep that toothbrush back behind the teeth, it's on what we call the retromolar pad, and once it's back there, the child will open up and probably get really mad, but they'll stay open. Next, you want to dry the teeth with a cotton gauze. You don't actually have to dry the teeth if you don't have a lot of time. It facilitates the fluoride uptake a little bit better, but it's not necessarily necessary. So you can just swipe the gauze quickly across the teeth. And then you quickly want to paint the varnish on all the sides of the teeth, both front and back, and the chewing surface. This picture makes it look like you're painting a Monet, and you're not. You're just going to slap that varnish on as fast as you can. So if you have a child that's super uncooperative and you think, oh, I'm only going to get a varnish on a few teeth before they completely freak out, you want to keep track, or just keep in mind what teeth are most likely to get decay and start with those teeth first. So if it ends up that you aren't able to do certain teeth, those lower front ones obviously are the ones that are least likely to need fluoride varnish than other teeth. And then you want to set the child up and have the parent cuddle them while you give post-varnish instructions and talk more fully about the appointment. So these pictures and instructions are summarized in the AAP flip chart that I talked about, as well as the documents that we have called 3 Simple Steps and Fluoride Varnish Application. So fluoride varnish instructions, post-varnish instructions, are different than traditional foam or gel fluoride treatment post instructions. The varnish sets with saliva and water, so it's not necessary to wait 30 minutes before eating or drinking. Keep in mind, though, that hot things after fluoride varnish can melt the fluoride off, and sticky stuff or really hard things can pull it out of the grooves of the teeth. So you want to minimize eating those for the rest of the day. The varnish ideally should be on the teeth for several hours, and they can even wait till the next day before they brush. Children that are at high risk of caries should have fluoride varnish 4 times a year. We have what you need to know about fluoride varnish document in English and Spanish. That's a great take-home for parents. It's got pictures and large font, and it's a little easier to read than the very tiny ones that come with fluoride varnish. In the past considered controversial, the use of interim therapeutic restorations or atraumatic restoration therapy or scoop and fill, different names for the same thing. It's become much more commonplace in the stabilization of early childhood caries, particularly for general dentists. The AAPD recommends that use of ITR to restore the teeth and prevent caries in young patients, children with special needs, uncooperative patients, or in situations where traditional restorations are not feasible. So with little to no discomfort, early to moderate early childhood caries can be stabilized in a matter of minutes, decreasing the need for referral and extensive hospital-based dentistry. ITR treatment can be quickly completed without local anesthetic, providing a much more positive dental experience for the child and for their parent. ITR can arrest early decay and stabilize moderate decay. However, due to the temporary nature of the material, it's important to monitor these patients closely with their oral hygiene and eating habits, and also watching the margins of those filling materials. And you want to make sure you supplement with fluoride varnish. So ITR and fluoride varnish are procedures that are easily done by the general dentist. Since many parents fear any sort of dental treatment, there's a chance not accessing dental care for their children is due to parental fears. As medical providers, you can suggest that some dentists can place fillings in baby teeth that do not, and they don't need shots. So without diagnosing or giving an actual treatment plan, you can help alleviate some of those dental fears. I've been asked how to code these ITR fillings. So for dental providers, so when you're coding, you want to use the 2940 for interim therapeutic restorations. Since a dental sealant is coded 1351, the coding says that if it's just limited to the enamel, the resin, or the glass ionomer, if it's limited to the enamel, it needs to be considered a dental sealant. And if it goes into the dentin of the tooth, then you would use the 2940 for that coding. So having a 0 to 3-year-old in a general dentist office is actually not very common, and many general dentists aren't really comfortable with treating or even examining these very young patients. Medical providers have a much higher comfort level with treating young children. So these tips are primarily to help dental providers as they start seeing young children. I recommend that you utilize your staff members who are most comfortable with young children and try to schedule the bulk of the appointment with those staff members. You may have a dental assistant who really likes that very young child, or a dental hygienist that likes working with the really little kids, and so you want to have most of the appointment with them And the person that's less comfortable, possibly the dentist, can just come in for a brief exam. Also, you want to make sure you're using that knee-to-knee technique, especially for the little tiny kids. The young child is much more comfortable with the parent there engaged and sitting on the parent's lap and having the parent there. Also keep in mind that young children cry. That's the way they express themselves, and they can't stop you and say, excuse me, I need to take a break here. So they need to express themselves through crying, so that's natural. You might want to consider scheduling these appointments when there's less of a chance that a stressful procedure is taking place in the next operatory. So you don't want to schedule something where a child might be crying and you're doing a root canal in the next operatory and having increased anxiety already. When you're working with this very young child, you want to make sure that you're engaging the parent and teaching the parent what to monitor at home. As the child gets older, you want to make sure you're explaining to both the parent and the toddler what you're doing and engage them in the practicing of toothbrushing skills. Another important thing is to use a calm, soothing voice and minimize additional noises. And that helps to decrease anxiety for the child and for the parent. And providing positive reinforcement of good behavior and good habits that the parent might already be doing is a great way to make sure that you're getting the parent on board with what you're doing. Lack of cooperation at home is a common excuse for parents not being diligent at home with toothbrushing techniques and with oral hygiene habits. So you can remind the parent that this habit is no different than other habits we teach our kids, like taking their vitamins or washing their hands. And the key to habits being formed is consistency, consistency, consistency. Some of these tips are that we just talked about can be used by parents in the home also. Minimizing outside influences and using a calm voice and expecting that the first few times the child's going to likely cry. Documenting services is important for many reasons. Not only is it important for billing purposes, but it also helps determine if the child has improved their risk of caries based on what was discussed at the last visit. You can also track whether a patient is regularly seeing a dentist. It will improve the utilization of your time so you aren't repeating the same information if it's unnecessary. If you're using paper charts, there are labels available on our website that you can use to stick in the charts. Otherwise, in electronic charts, you can add smart phrases to your intake forms to ensure that all ECCP elements are covered. Here's an example of some smart phrases that you can use. You might want to have yours be a lot more comprehensive than this, particularly if you're a dental provider. But again, medical providers want to have things as easy and as quick as possible since they're trying to get a lot done during that well-child visit. Both the smart phrase examples and chart labels can be found on our website. There are a lot of different ways that a clinic can implement these services into their workflow. Here's, we have a few examples of flow charts and diagrams that might work for your particular office. So in this first one, the parent or caregiver and the child arrives for a well-child visit, and they may notice that there's new posters or education materials in the waiting room that they haven't seen before. So reading information might be their first introduction to some oral health messaging. As the medical assistant brings the parent back, they can ask if they're established into a dental home and give some early childhood caries prevention education as they're already getting some of the vital signs that they take already for the well-child visit. When the medical provider does the exam, they can do their risk assessment screening and put in their order for fluoride varnish or place the fluoride varnish on the child. Some offices, the medical provider just assigns that to the medical assistant after they leave the room, while other times the medical provider just does it while the child's mouth is open. Making the referral to the dental home is, of course, very important. If the child already has a dental home, that's great. If they don't, you can make that referral. If they have really limited access, you can just continue to monitor these children in your office. For dental providers, there's obviously many ways that you can implement. You can do like a traditional visit where the dental assistant or hygienist does most of the work, and the dentist reviews the findings, comes in for the exam, and explains interventions if necessary, making referrals as needed. Or you can do more of a group sort of appointment, like is demonstrated next. A Baby Days is a sort of an appointment that Virginia Garcia Memorial Health Center, Multnomah County, for example, use to see their 0 to 2-year-old children. The parent makes their appointment for Baby Days usually through or at the medical appointment. These can also be done at WIC or Head Start or in the medical office. And the parent arrives for the Baby Days, and they check in and pay, or if they don't have to pay for the services, if you do it that way, that's fine. And then the dental assistant or the dental hygienist usually shows a DVD and then provides additional information from the front of the room. And then the dentist or expanded practice hygienist can then do their caries risk assessment and provide anticipatory guidance, fluoride varnish, and treatment plan with the family. So this is some pictures of what Baby Days might look like. This is the McMinnville Virginia Garcia Memorial Health Center. We had about 5 family units, but traditionally we see between 5 and 20 family units at a time for Baby Days. The family units watch a DVD on early childhood caries, and then they have that group oral hygiene instruction and nutrition lesson. And then the staff goes around individually to each of the family units and introduces brushing and makes sure the parent is well versed on how to check for their kids' teeth. Then as the families are receiving one-on-one assistance, the dental providers usually set up to do the exam, and just one at a time the families come back and they get their exam. They get through this Baby Days, they get that quality education and exams in a relatively short amount of time. It's not uncommon to see large numbers of family units in 1 hour of time. And some populations, I know particularly the Hispanic community, they really like group lessons and group activities, and so that's a great way to see large numbers of families. In the state of Oregon, fluoride varnish is reimbursable. Since this webinar has medical, dental, and out-of-state attendees, we're not going to go into specific billable details right now. This is covered much more detail during our implementation of our first tooth training. In addition to varnish reimbursement, some reimbursement might be available for additional dental screening. With the changing landscape of the Oregon Medicaid system and the CCO transformation we're experiencing, keeping this information updated is actually one of our biggest challenges here at the Oregon Oral Health Coalition. Fortunately, we have many excellent resources to assist us in helping clinics and organizations to provide those services and get the reimbursement that they want for those services. Dental providers are also seeing changes in reimbursement codes and rates. So we're trying to keep abreast of all these changes, and again, we have excellent resources to help offices as needed. And this chart summarizes some of the codes that are used for assessment and for varnish. Again, we can go into more detail when we do the one-on-one training, or you can contact us if you want more information. OHP eligibility, providers who see Medicaid patients, I'm sure you already have access to these OHP portals, and you already have the information to check eligibility and verification of services. Yeah, that's it. It's really important to assign referral coordinator in the clinic, particularly for medical. And the referral coordinator in the clinic can contact the patient's DCO to get a direct referral for services. They can make occasional phone calls to some of the referral sources to make sure that these sources are still taking their patients. Sometimes it's challenging if we give out a referral source and then the family calls and they find out that, oh, we don't take them anymore. So a referral coordinator can help those communication lines stay open. One of the challenges that I hear over and over again is that medical providers say that they're on the phone trying to find a dentist. And I just think that's a fairly inefficient use of the clinic's resources if the medical provider is actually on the phone trying to find a dentist. So if you can get the referral coordinator to do that in advance, it makes it easier to make those referrals. The website listed here lists all the DCOs, or dental care organizations, by county in several languages, with their phone numbers and their website information about each of the dental care organizations. Again, with the CCO transformation, these things are in flux. The Dental Home Initiative, Head Start Initiative, drafted a document that's entitled DCO 101. It provides great information and directions on how to help patients find a dentist. And so we have a copy of this document on our website also. However, again, though, that with the CCO transformation at all the various stages that it's at, there's regular changes to reimbursement and also to how referrals are made. We provided a checklist to help implement these ECC prevention services in the medical home. It's important to determine who's going to deliver the services, particularly when you have an office that's fairly large. So it could be either a combination of a medical assistant, an RN, or a medical provider, depending on the flow of the appointment which you're delivering the services. So you need to decide when the services are going to be delivered. Like you might want to coordinate the fluoride varnish with immunizations or well child visits and mark those at 6 months, 9 months, 12 months, et cetera. Separate visits might be needed for high-risk patients if you need to see them more frequently than the regularly scheduled well child visits. It's important to identify that oral health champion in the office to make sure that the supplies, varnish, and handouts are ordered, making sure there's enough educational materials for the families, identify and incorporate the prompts for the providers built into the system, and ensure that new employees are getting the training that they need. It's important to determine a plan for fluoride varnish and educational materials, as in who's going to order, where they're going to be stored, who's in charge of getting the supplies ready, who's going to be scrubbing the charts, and that sort of thing. It's important to determine who's going to coordinate the dental referrals and ensure that that dental referral information is handy either in the exam room or at the front desk. And then establishing that process for documentation. For example, are you going to use, if you have paper charts, are you going to use stickers or other kinds of prompts, the intake form, different exam forms, that sort of thing. It's really important to keep a record of assessed risk and when the screenings were done, any anticipatory guidance that was given, and the referrals that were made. And then you want to create a process for eligibility for fluoride varnish, in particular scrubbing charts as needed. And these are all things, again, that when we work one-on-one with an office, we can help improve those workflows to make it easy transition to provide these services. So one exciting thing is that this sort of thing can be done. It may seem daunting or it may seem really easy to you depending on how you want to incorporate it. A lot of flexibility is important when you're starting an ECC prevention service program, because you may decide, oh yeah, it works really well for well child visits, and then decide later that maybe it doesn't work so well there. And so having some flexibility to your program is really important. In the dental office, integrating that young patient is really important. Medical providers throughout the state say to me, we just don't know who to send our young children to. So if you are a dental office and you're going to see young children, get the word out to your local pediatric providers. Utilize your staff creatively to provide these services. Think outside the box. And then using educational materials, either handouts or DVDs, can decrease the amount of time that you actually spend talking in the medical visit, in particular when you have very little time. If you're interested in scheduling a first tooth training for your office, please contact Philip Giles, and his information is right here on this slide. We want to thank you for joining our webinar today. Philip has some closing remarks to end the webinar. And if you have any questions, you can put those in the box on the side, right? We've got a couple of questions that we're going to go, we've got 4 questions right now. How many teeth does a baby need to have to get the varnish? And do the first 2 teeth barely being in qualify? So that's an excellent question. You can start applying fluoride varnish right away. You can also keep in mind, though, that those lower front teeth are teeth that traditionally do not get early childhood caries. So they definitely qualify for getting the fluoride varnish, but it's not as imperative, of course, as those upper front teeth. I hope that answered your question, Mr. Potter. Do you have access to the AAP flip chart and pocket guide? Yes, on our website, www.orohc.org. Same with the handouts. And we can send the PDF of the slideshow to the attendees if they ask for it, if you request it. To answer your question, Ms. Greek. And then I think that Phil has a couple of other, another question, great. How do I find more information on motivational interviewing for training dental providers? That is an excellent question. Not exactly sure I know the answer to that. However, I can find out the answer and get back with you on that. Thank you for asking that, Kim. I will definitely get back. Please forward. Oh, okay. Any other questions? Some of you are sending in your request for the slides. Great. Go ahead and do that. Oh, another one. Who normally ends up being your dental referral coordinator? So I'm assuming you're talking about in a medical office. So usually the dental referral coordinator is the same referral coordinator that you have. They just add a little bit more tasks to that person. They may already be making dental referrals, and I would just recommend that they contact local dental offices to make sure that you have a list of dental people that you can send your children to. The website again is www.orohc.org. Wait for just a couple more minutes in case there's any other questions that I might not have answered. Here we go. No contraindications. Okay, the question is, I noticed you mentioned there are no contraindications to fluoride varnish applications. Did you come across any research-based evidence regarding issues with clients who have asthma? Excellent question. So I said there's no evidence-based contraindications to fluoride varnish applications because sometimes when you get your fluoride varnish, they say not contraindicated for people with pine nut allergy or with chronic gingival stomatitis, that sort of thing, but have not found any research-based evidence regarding any contraindications at all, asthma or anything. But that's a great question, and one that we will continue to look up to keep in mind. Oh, great. There's a book by Phil Weinstein on motivational interviewing in pediatric dentistry. Thank you, Dr. Schwartz. So that question is directed to Kim. Motivational interviewing. That's right, I actually have read that. Phil Weinstein, Motivational Interviewing in Pediatric Dentistry. If a child is in for a 3-year well check and about to go to the dentist, do we varnish those kids? I would recommend going ahead and giving those kids varnish and just making sure that the parent knows that they've had that so they don't need to have it at their dental office. Because you want to make sure that they are getting it and they may cancel that dental appointment. What has been the take-up of First Tooth in Multnomah County? Very popular in Multnomah County, as per Phil sitting next to me. How did you decide to focus on dental providers of all types rather than just dentists for this training? I think the reason why we focus on dental providers of all types is because in Oregon we have expanded practice dental hygienists, and a lot of times the expanded practice dental hygienists are also going particularly into the field, like at WIC and Head Start, and providing some of these services. We also do training at dental hygiene schools and have offered training at dental schools and dental assisting schools so that everybody has the overall education, even if they're not qualified to particularly apply the fluoride varnish on their own. Was the AAP flip chart provided to all medical practitioners?
It is provided in
It's okay. So when we do an in-person training, we give for medical providers, we have a toolkit, and we call it our little toolkit. It's a little clear box that has all of the educational materials that I showed you and more that I referred to. It also has samples of fluoride varnish and little child toothbrushes. So yes, that's provided in an in-office training, but you can access that either by the AAP website and order one directly, or you can order through our website. You have to pay the cost of us to produce it and send it to you because they're expensive. They're really nice flip charts. I don't know if you haven't seen them. They're really, really great flip charts, and so they're expensive for us. Are there special storage requirements for the varnish, and how would a family practice office go about obtaining the varnish and supplies? Great question. I don't think there's special storage requirements, although naturally you wouldn't probably put it in something placed really hot. But a family practice can obtain the varnish and supplies through any of their medical resource companies. Like we have a list of options or ideas for you to order the varnish through either your medical supply companies is usually how you would do that. And toothbrushes, there's a lot of great toothbrushes out there. The company called Plaquesmackers, Plaksmackers, has a very great supply of really nice little toothbrushes for very inexpensive, like 18 cents a toothbrush or something like that. Do you ever train lay people to apply fluoride varnish? Is this allowed in Oregon? Can people bill for that if they are not typical medical providers? So yeah, we have a lot of lay people come to our trainings. I mentioned that we partner with WIC and Head Start and other child care providers because we want everybody to have the education and that consistent messaging. So once trained through First Tooth or through another training program, I suppose it's legal in Oregon to apply the fluoride varnish, but you can't bill for that unless you are a medical provider or a dental provider. We started First Tooth a week and a half ago. How do we know if we should varnish or if WIC should? We are seeing the patients who are getting it done there. Awesome. Very glad to hear you guys are getting started. That's an excellent question. I would probably, if the parent isn't a great historian and doesn't know how often they're getting it, and you know for sure they're getting it at WIC, I would say that you wouldn't need to double up on that. One of the great things about fluoride varnish, though, is that chance of toxicity is so low because it doesn't get absorbed. So if they accidentally get more than 4 times a year, it's probably not going to hurt anything. But if you know they're getting it 3 or 4 times a year at WIC, then you don't need to do it. Great question. Why can't medical and dental providers provide fluoride varnish, and why does one negate the other? Ms. Crafton, I don't quite understand the question on that. If you can maybe reword that question, that'd be awesome. Just wonder if the medical associations support the need for early oral health care interventions through any kind of resource provision or enforce standards for early screening with young children and infants. That is a great thing. I would wonder also, and maybe some of the medical providers out there that are involved with their associations can comment on that. That would be excellent. I would love to hear your comment on that. Sorry if we missed it, but will the slideshow be sent out to attendings of today's webinar? Yes, if you contact Phil and ask him for it, he will send that to you. Let me go back to this by Ms. Crafton. Why can't medical and dental providers provide fluoride varnish, and why does one negate the other? Oh wait, maybe we're getting it. Sorry, you pretty much just answered it. Okay, great. Thank you. Okay, are there other questions? I'll just give another minute here for any other questions. Oh, okay. Another minute for questions, and then Phil has a couple of housekeeping things at the end. Okay, Dr. Schwartz says, I think the fact that the Academy of Pediatrics has published both the flip chart and the risk assessment tool for pediatricians should be proof of commitment. I agree with that. They also, I wanted to mention that they also partner with the Smiles for Life curriculum that you can get online, which is a, they really support the additional training throughout the lifetime of the patient, but their project that they have partnered with Smiles for Life is a really great project. And you can access that on their website. All right, here's Phil.
Okay, well, thank you all so much for taking the time out of your busy schedule to learn more about First Tooth and how it can help your organization and community. First Tooth is a resource for the entire state of Oregon. No area is too remote. No office is too small. We train all medical and dental providers and their staff. Please contact Phil Giles, Philip with 1L, Giles, G-I-L-E-S, at ocdc.net or visit www.orohc.org for more information and to schedule a training. We do have one more question. If our patient has not been to a dentist yet and are over the age of 3, is it appropriate to varnish? Yes, and you can bill the medical office until the age of 7. And with that, I'd like to wish everyone a safe and happy holiday, and thank you for joining us.